Welcome to another episode of the Root Cause Business of Medicine podcast. And today's guest is Jessica Craig, a journalist, our second journalist that we've had on, Davin. What were some of the things that you got from our discussion with her today?
Well, this was a topic that we wanted to go a little deeper in any case, which is around kind of that direct pay model, right? And kind of what are some of the pros and cons, or what does that actually mean to different people? And so I thought it was really timely that there's a journalist out there raising awareness, helping people understand that there is an alternative model to the insurance-based practice. Not only in primary care, but also for some of the specialists as well.
Yeah, and I thought it was fun in our conversation about where the future of business of medicine is going, right? A lot of times we ask, what's the future of functional medicine or integrated medicine? But today it was like, okay, well, how do we get this shift to happen where patients can get better quality of care, physicians can have better quality of life, and we have a better revenue generating model to cover it with insurance or not insurance, direct primary care. I thought all of those things came out and were flushed out with a very interesting discussion.
Definitely.
All right, we look forward to having you join us on today's episode. Welcome to the Root Cause Business of Medicine podcast, where we explore what's broken in healthcare and what we can do about it. I'm Dr. Erik Lundquist, and I've been practicing functional medicine for the past 15 to 20 years. I'm excited to co-host this podcast with my brother, Dr. Davin Lundquist,
who's just beginning his journey into functional medicine. We come from different points on the path, but we do share a common goal. We want to rethink how medicine is practiced and help others do the same.
The U.S. healthcare system is in crisis, rising costs, declining outcomes, and physician burnout at an all-time high. But we found a different way, another way, a better way.
On this podcast, we dive into real stories from medical professionals who've stepped away from the traditional model, kind of like me, and have found a new purpose in integrative, functional, and alternative approaches to care.
These are authentic conversations with practitioners and friends who redefine success, not just for themselves, but for their patients and communities.
Whether you're a clinician feeling stuck, a student seeking direction, or just curious about what is possible,
you're in the right place. This is the Root Cause Business of Medicine podcast. Welcome back to another episode of the Root Cause Business of Medicine podcast. And today our guest is Jessica Craig, who is a health reporter for the Straight Arrow News, which is a relatively new online news agency really dedicated to unbiased reporting. And Jessica Craig has a background in infectious diseases, has lived in Africa for a period of time, and is really kind of jumped into this space of changing of medicine and become passionate about really looking at the scope of how medicine's changing and how new practices that seem to be popping up, that seem to be thriving, are all more in the cash-based model. And so, Jessica, welcome to the podcast.
Thanks so much for having me.
So, Jessica, give us a little background on kind of how you transitioned from infectious diseases into reporting on the state of business medicine and kind of what's going on in the cash-based medicine world, and why that intrigued you and kind of lulled you into starting to write about that.
Sure. So I worked for about a decade as an infectious diseases epidemiologist and technical advisor for several U.S. government agencies. Was at USAID last year when the agency closed down. I'd always dabbled in journalism, and I felt really a calling at that time to give journalism, my full attention. I had just moved back to the United States after being overseas for a while, and I think, it's no surprise to anyone that our healthcare system is really having a lot of challenges. I think we're really facing a crisis on several fronts. And so I started reporting on our healthcare system and health policy, and I was really wanting to explore viable solutions. I think broad political reform is probably not coming. And so I wanted to know from the physicians who are actually practicing medicine, what are some of the solutions they're excited about? And this cash-based clinics, cash-based care model kept coming up from people of all different specialties. And so I decided to really look into that. And at first I thought, that sounds like a solution maybe only for a small portion of Americans, and I wanted to know if that was really true. And one of our missions at Strader News is to really be bipartisan and really explore solutions. So I jumped into it, and it was really interesting to find that it does seem like a great, viable solution in some ways, and certainly is taking off.
Yeah, I think it's really interesting how much this movement has really um, taken place over the past several years. In fact, it has tripled in the number of clinics that have adopted a direct primary care option. It's interesting to note that their estimates right now is that in 2035, the concierge medicine market will be around $46 billion. And the other key fact that I found interesting kind of researching about this is that the dropout rate is significant. Burnout rate in terms of physicians is way less in those who adopt a more cash-based model than in those who are, continuing to slug it out with insurance. If you come across any of that kind of data, or what have you seen as you've kind of explored the market?
I think maybe from the outset, I hear this question from a lot of people, and there's maybe some confusion about what cash based care is. And I think that's largely because cash based care is not one thing. It's many different models that are starting to emerge. They all are, founded on one central idea, which is, basically that we need to get back to paying for healthcare services more directly, bypassing the healthcare industry. So we see that in a few different ways. We have direct primary care, which is becoming more common. The exact models of how patients pay physicians varies from practice to practice, but one common one that I see is physicians charge like a monthly subscription fee. It's $100 to $150 per month, and that covers, unlimited number of visits to the clinic and all of the services that a physician can provide in a primary care setting. In direct primary care, we're definitely seeing this is becoming more common. I think the American Academy of Family Physicians, I believe, they do an annual survey, and they found in the past 4 years of their members that the proportion of physicians who are in direct primary care has increased from 3% to 11% in just the past 4 years. And I was trying to get an estimate for my reporting of how many clinics out there are doing direct primary care and how many patients are they serving. And it's a little bit difficult to find concrete numbers, but my best estimate is there's probably 2,500 to 3,000 cash based clinics, probably serving around 1 million Americans. So that's overall a pretty small chunk of the field. But there are also other types of cash-based care. We see specialty care, surgical centers, even some oncology clinics that are starting to pop up, and they're entirely cash-based. In fact, one of the physicians that I interviewed for my piece, Keith Smith, I'm sure you both know of him. He was definitely a pioneer in this field, and he's an anesthesiologist who runs a surgery center in Oklahoma. So there's direct primary care, but there's also a number of specialty care clinics popping up. And the whole idea is, again, they don't accept health insurance. It's an upfront fee for a service. One of the hallmarks of these, which I find interesting, is that there is a transparent fee. You know exactly what it's going to cost when you walk in the door, whereas sometimes walk into a doctor's office, you have no idea what's gonna cost you. And then I'd say there's a somewhat distinct segment of cash-based care, which is more focused on longevity and optimizing health. And I think of that a bit differently because I think it serves a slightly different patient population and solves a slightly different problem with our healthcare industry. And that's more. for people who are looking for advanced diagnostics or performance-focused care as opposed to direct primary care. And so I don't think it's solving the same sort of access issue as direct primary care. But those are three examples of like direct to consumer care. There's also another trend of direct to employer contracting, which is when employers and companies again are bypassing health insurance and they're going to health providers directly and negotiating different contracts. Historically, you saw a lot of large employers doing this, the Boeing, Walmart, Intel, Disney. Sometimes that was they went to a network of clinics and they negotiated a contract. Sometimes that was bringing a primary care physician onto their company campus to provide care. But I think over time, what we're seeing is as health insurance becomes increasingly unaffordable, a lot of smaller companies are starting to do this too. And the latest numbers that I could find were from 2025, and they estimated that about 40% of large companies, so those are companies with more than 50,000 people, are entering into these direct negotiations with health providers. And just over 20% of small companies, which have fewer than 1,000 employees, are starting to do this. So I think when you take that all together, we're certainly seeing this is taking up a larger share of the market.
What about, telemedicine as a segment of that? Did you look into that at all? I feel like there's a lot of people that use low cost telemedicine visits as like their entry point, or maybe their own version of primary care.
Yeah, absolutely. It's telehealth, but it's also, I hear from a lot of direct primary care physicians who just say their patients can call them on the phone with a question. At midnight, my child has an ear infection. So it's a lot of telehealth and it's a lot of just, returning to direct communication with your physician.
No, I agree. I think the direct primary care model is all inclusive, certainly in this day and age, post COVID. But I also just wondered, if the telehealth space was kind of, in a way, the first one to really broadly just have people pay directly, right, for a visit. And so I just wondered if that was part of your analysis.
Yeah, I didn't find numbers on telehealth specifically. It can be difficult to find what models different telehealth companies are using, and it's difficult to find concrete numbers on all of this. So those are the best estimates that I can find in terms of trends. And I definitely think we're seeing an increase. It's becoming more popular, and I think we're also starting to see more research behind this too. So we'll probably have some better estimates of how big a trend this is.
I totally agree. Maybe break down a little bit more what you've seen in terms of the different types of models out there from. I mean, you kind of gave us some broad strokes, but I think even within, the membership model, sometimes people get confused. Like, what's the difference between a DPC versus a fee for service versus a membership versus a concierge versus, a insurance based membership. I mean, there's all these different. Maybe break that down for us a little bit and what you've come across in your research. And do you have any, as a secondary question, do you have any background sleuthing that you've done to discover where in the world did we get some of these terms like concierge medicine, things like that?
Yeah, I think a lot of physicians, they're leaving conventional medicine and pursuing cash-based clinics. And I think part of that is understanding the community that they're serving and understanding the best way to serve that community. And so I've heard all manner of unique ways of tailoring payments and fee for service care. I think that looks different depending on the physician and the clinic. I know one clinic up in Wisconsin, some of their patients, they're in that gap where they don't qualify for Medicaid, but they can't afford other health insurance, and sometimes they bring in chicken and eggs to pay their physician for services. So I really think there's a lot of flexibility, and I think there's any number of different combinations and payment methods that physicians have come up with, and I think it's really about just understanding what works best for that physician and what works best for the patients that they're serving. There's that direct primary care model, membership based or subscription based, what people call it. But then I think there's also, when you talk about more concierge medicine, there is some element of health insurance sometimes. I think there's also, as I was mentioning, a big difference in what types of services physicians are providing, from primary care all the way up to, more longevity, biohacking sorts of services we also see.
Yeah, I know. I've noticed that, at least in some of the research that I've done too, that the number one reason people seek out direct primary care programs is access to care.
Mhm.
Right. One of the challenges I think that we're seeing in medicine, and I hear this from my patients, okay, I referred you out to a neurologist and they can't get in to be seen for 3 months. Or even, if they want to come back in and be seen by their primary care provider, and they often end up having to go to acute care clinics or the emergency room, because those clinics are so overburdened. And a lot of what drives that is insurance reimbursement, right? At least I know in our own clinic, one of the challenges that we've faced is that over the past 10 years, the amount of revenue that we get from insurance in terms of per visit hasn't changed at all. We continue to receive the exact same amount that we were paid in 2014 that we're getting paid today. But of course, overhead has significantly increased. So the only way you compensate by, in other words, bringing more revenue in, is to see more patients, because insurance is still a volume-based practice. And so I think one of the things that we're seeing is that part of what's driving this is the fact that patients want better access to care, one thing. And then I think providers want to provide better care. And you can't give a patient good quality care in a 7 to 15 minute appointment, particularly if you're trying to take a complex patient with multiple problems, trying to figure out what's going on in their background. You can't get that. Is that what you're kind of seeing is you're researching out? Is that kind of these two major driving forces of patients wanting greater and better access, and providers wanting to provide better care and actually have better quality of life in their practices?
Yeah, I think those are the two biggest drivers. Physicians want their autonomy back. They want to be able to make the best decisions based on the science and the evidence and their compassion, which is why they went into medicine in the first place. I think health insurance has really stripped a lot of autonomy away from physicians, and consolidation, private equity firms buying up hospitals has also further exacerbated the problem of patient volume. And then on the patient side, you wait months to get in to see a doctor, and you get to see your doctor for 10 minutes while they have their nose in their computer the whole time, which is not no fault of the doctor. I understand why that is. And you don't get to address all of the problems. You maybe get to ask a few questions. And we talked a lot about we can address nutrition and primary care, and there's a lot of lifestyle conversations to be had. Well, you can't have that in 10 minutes. And just a few weeks ago, the Department of Health and Human Services announced that more medical schools were going to have more nutrition training for doctors. And well, that's great, but you can't still address nutrition and everything else you need to address in 10 minutes. And if there's no billing code assigned to that, then it's not going to get done. And so I think, you know, patients are really seeking better care. And I think in the vacuum of that, you see patients turning to social media or podcasts or whatever it is for information about health, which is also driving, a lot of misinformation. I think it's driving a wedge between the patient physician relationship. And I think physicians are just really getting burned out. I just reported a piece a couple of weeks ago. What started out was burnout, and then it moved into moral injury, and I settled on demoralization of America's doctors. And they all, and I'm sure you all have your stories too, of I needed to do this for a patient, but insurance would only cover this, so I had to do this. And I know every doctor has that, or they're fed up with having to see 30 patients a day and then go home and work for hours more, spending time on all of their notes. And I asked them, some of whom have left medicine altogether, some have transitioned to cash-based clinics, and I asked about some of the solutions, and the majority of them pointed to cash-based care as a solution that really is emerging. not only to restore autonomy to physicians, but also to empower patients and to allow them to really have time with their physician to understand their own health. And then I think employers also have a huge advantage here too. I think there's a statistic out there that the average U.S. company spends $18,000 per employee each year on healthcare. Imagine if they moved to a more affordable system, how much money they would be saving, and they could maybe pass those savings down, and salaries could maybe keep up with inflation for once. So I think there's a lot of benefits to be had across the board.
Yeah, I agree. And in talking with one CEO about that, I said, okay, so if we made these changes, would that really help save money? And interestingly enough, it typically is just a handful of patients that end up driving that cost way up. You get a patient with cancer, you get a patient in an accident, and that's what ends up driving those is the overall the amount that companies are spending per employee tends to be relatively low, except for those high utilizers. And so that makes it a challenge, right? Because how do we do a better job then of preventing some of these more catastrophic? I mean, we're seeing more and more individuals with cancer, more and more individuals with cardiovascular disease, more individuals with strokes, more individuals with autoimmune issues that are leading to, chronic illnesses that are impacting productivity, right? And so those are the patients who really tend to drive up the overall costs for everybody. And the other 90% of the patients who don't have some of those issues aren't. But if we could do a better job of just even preventing some of that 10%, then we would keep more people in the workforce.
Yeah, and primary care is really the foundation of our healthcare system. And imagine if you had more time with your primary care physician to really prevent diseases before they came about, how much that would save everyone in the long run. And so that's where I really think cash-based care could really shine is at the primary care level. It would require a bit of a mentality shift in Americans who still, they're shielded a lot from the cost of healthcare. Even when you get health insurance through your employer, you don't see that cost day to day. It usually gets taken out of your salary before you get it. So there's no tangible understanding of these costs. Um, so, there will take larger shifts to really solve some of these problems, but I think primary care is a really great setting. I was interviewing a primary care physician who switched to cash-based care a few years ago, and she said, we ought to be using health insurance more like it's car insurance. When you go buy gas or get your tires changed, you don't draw on your car insurance. You do that when you get into a big accident. And so that's how she was saying we ought to see health insurance used, where the primary care, these are small expenses, maintenance, prevention, and then it's when you have the cancer diagnosis, the knee replacement surgery that you draw on health insurance. And so she was saying the cash-based model in primary care with the catastrophic healthcare plans, which are starting to come back with some new policy changes, they pair very well together.
Yeah. Go ahead,
Have you
Dan.
done any have you done any analysis on, like, from an insurance perspective? For instance, there, over the last decade or so, a lot of these managed care or capitated, models have evolved. So, for instance, a large medical group may receive, so many, dollars per member per month, to sort of take care of a population, from a primary care standpoint. I don't know that those numbers reach sort of a direct primary care, membership level. But, that might be an interesting comparison to say, hey, rather than paying these large groups, PM in a capitated model, could you sort of shift those dollars towards a direct primary care model? And then, either, the employer continues to cover that, or maybe that's carved out, and the overall cost of insurance drops, and that sort of primary care carve out, if you will, could be a nice hybrid model. Have you seen anything like that? Do you have any data on, like, how much insurances spend on primary care utilization, or any of those kinds of figures?
I don't have any of those figures at my fingertips, but you could just think of how many middlemen you would be nixing from the system if you did this. I mean, it's the insurance companies, it's the pharmacy benefit managers, it's all of these intermediary companies that have
Yeah.
popped up to facilitate this system. I mean, imagine the cost savings of just getting rid of their administrative overhead costs. That would be millions in savings right there.
Right. Well, and that's what, we had a guest on early on, Aaron Wenzel, who's a concierge medicine doc from Nashville. And one of the things that he pointed out is who are the stakeholders involved in the care of the individual? And in a direct primary care model, the stakeholder is the patient and the physician. There's no other stakeholders, right? But as soon as you start bringing in an insurance company, these, uh, pharmacy benefit, coordinators. You have more administrators, then you have like those medical directors that are reviewers. There becomes multiple stakeholders, and ultimately, the physician and the patient are beholden to these stakeholders. They're not even the primary stakeholders in the decisions being made about the healthcare of that individual. And I've always thought it weird, like, nobody would go to a grocery store and load up their grocery cart, get up to the register and have them say, all right, well, we'll bill your insurance for your food and we'll let you know what your ultimate bill is. There's a copay of $50 today, and then you'll get a bill later from your insurance to determine exactly how much you owe on the food. And then you get a bill for twice or three or four times the amount that it would cost you cash wise to get that same kind of food. I mean, that kind of a business model would never work in any other industry. I don't know how we've allowed that to happen in medicine.
Yeah, I think we took something that seemed like a great idea, health insurance, so defray some of the risk, and it's gotten so out of control. And I think federal regulation has also contributed to that with the administrative burden, the reimbursements, the amount of time. There's, the estimate more than two administrators are needed per physician providing care. I think those costs are like 30% of healthcare spending now, just administration. And you're right. I think the other big thing is the impact that those stakeholders have on clinical care has really eroded people's trust in our healthcare system, and it has eroded quality of care. And I think that's why so many doctors are trying to leave medicine and driving our issues of burnout and moral injury, and no one wants to go into medicine anymore, and that's because of this monster that we've created. And I don't know how. I don't think the system can be untangled. I think it will have to collapse before we find real solutions. But certainly, the cash-based clinic is sort of this parallel system that is starting to emerge.
I think that's great. And, a couple other scenarios, having practiced in large health systems, I think Erik and I both started in the Navy, which you could argue is a pretty large health system. And then from there, I've been, with some community health systems and then a large, nonprofit, one of the largest in the country in Common Spirit. And so I've seen, different models, and I've practiced certainly on the insurance side or the RVU based model, which the Navy wasn't like a typical insurance, but they still used RVUs back in the day. And so, but what's interesting is here's a couple scenarios that I'm curious if you've come across. So one was a patient recently who needed a prescription for a very, a very common medication. And, he went to the pharmacy and they're like, oh, that's not covered. That's that your insurance is not covering that medicine. It's going to be, so it'll be $150 or something was the cost. Right. And I said, well, go back and ask them, say, well, what if you use like a good RX cash discount, can they reprocess it? And then it ended up being like $15 or something, and, the gap there between, that pharmacy benefit, manager, what they're recommending, the patient bill the insurance for, I guarantee you that money, that's the difference in that gap. It's not going to the pharmacy and it's not going to the patient. Certainly it's not going to the physician. Who's taking that difference of $100, in the cost of that medication that was inflated, right? So that's one scenario that's kind of interesting, the difference between cash and insurance, like Erik alluded to. And then another scenario it was in my practice with a large health system as a primary care doctor. Patients would call in, or they would, let's say they saw me as a visit and I send them home and I prescribe some medicine, some blood pressure medicine or something. And then they have a question about it a few days later, right? And so they call in, and where does the call go, right? It goes to a call center, and the call center person takes a message. And of course, they're going to forward that message to my clinical team, which includes my MA. So my MA gets the message, and she forwards that message on to me. And I'm like, well, are they taking 1 or 2 pills a day? Whatever, I don't know, some question, right? And so then my MA calls the patient. And, what likely happened is she probably left a message because the patient didn't answer on the first call, right? So then the patient gets a message from the doctor's office, hey, we have a question for you. So they call back. Who do they get? The call center again, right? So then the call center, which can't answer their question or even know what we were asking in the first place, and then pretty soon patients and MAs and call center people go through this cycle 3 or 4 times. Meanwhile, I have no idea. I have no interaction with the patient, right? Now, in a direct primary care model, which I've practiced in, they can send me a message directly to my secure messaging app, HIPAA secure messaging app. I get the message, I handle it in 2 minutes, and there's no back and forth. So those are a couple of scenarios I've seen, where the difference between insurance versus cash, and then the difference between like a big complex system and just that direct access to a doctor. What have you seen or found? Is that mirror some of the things you found?
Yeah, the other scenario I hear often, when I first started reporting on cash-based care, I thought, primary care, I could see this would work well in primary care, but surgery, oncology, are there really cash-based clinics out there, and who is pursuing that? And I found that a large segment of people who go there are seeking treatment because their insurance denied their claim, said they couldn't have a specific treatment, or they wanted to put them on a drug that their doctor said was not the best one that they should be taking. And so, they could afford to go seek out surgery or oncology treatment or cardiology care from a specialist and pay out of pocket. So I think that's another growing segment of people seeking out cash-based care, or people who are getting denied by insurance. And we have seen a pretty dramatic increase in the number of claims that insurance is denying.
Yeah, and I think this is only going to continue to get worse in terms of the divide, right? Because the more physicians who pull out and start doing cash-based practices, and Davin, to your point, the reason that you have the time to be able to answer that message from the patient coming in directly is because you're not having to see 25, 30, 40 patients a day, and therefore necessitate having a call center because you're too busy just trying to get from one appointment to another, let alone try and answer questions for patients, right? And so there's got to be a balance. But right now we're seeing, this small percentage of, according to the AFP, there's at least 11% of the total family physician population that's now doing direct primary care. My guess is that there's a greater percentage of doing some form of membership model that gives greater access, and maybe doing concierge or doing fee for service, or just have flat out gotten out of medicine. So that's keeps shrinking the number. We have fewer people going into primary care. I get at least once, maybe twice a week, recruiters asking me if I'm interested in joining some, primary care practice in different parts of the country. And the amount that is, when I first came out of the Navy, I took a salary of $120,000 a year, which at the time I thought was okay. But now I'm getting offers for 300, 350, 400,000 because they're desperate, right? And basically what it is it's a hospital owned practice. And so they have the resources And all they're doing is basically plopping a primary care doctor in there because they know it's a funnel for their services, which is where they make their money. And they lose money on all of the primary care practitioners, right? So there's going to be this continual divide. I agree with you. I don't think that the government or policy is going to correct this. What do you think is going to allow for the shift other than it just imploding? But do you think there's a realistic way? Is AI maybe the answer to try and help compensate for some of this? Is it more just getting the message out and patients, demanding better care and using their dollars? Or is it corporations that need to start putting more money into these direct primary care practices and supporting it that way? What do you think is the best avenue or solution, or is it multiple to get to this newer place where we have better quality of care, better patient satisfaction, better physician quality of life? What do you think?
Yeah, I think there is the inherent challenge with cash-based care is that can the solution scale? And inherently, it can't really because the inherent success of cash-based care and the draw to it is that physicians get to spend more time with patients, which means they see less patients. We already have a huge shortage of physicians, especially primary care physicians. And if, you go from seeing a patient panel of 3,000 a year to 300, well, that's really going to make our problem much worse. So it's not going to be the end all be all solution on its own. I think, not to mention the pinch point that that's going to create for people who do still use the health insurance model. What you might have behind are the sickest people who require the most complex care, and insurance is just going to continue to increase as you have people leaving that system. So I think we're going to hit a real pinch point. I think what maybe needs to happen is that Americans need to have just a paradigm shift in how we think about health. And I was thinking about this a bit earlier, just for myself. Would I go and to a primary care doctor and pay them through a cash-based model? And why do I felt like I had some resistance to doing that myself. And I was trying to think about why that is. And while we don't have universal health care in this country, by and large, most Americans get health insurance through their employer. So it feels still like it's a right. It's something that we get for free. It's a benefit. I shouldn't have to pay so much for health care. I shouldn't have to pay out of pocket, even though we are paying for it, being a part of an employer-sponsored health insurance. We just don't see it. So I feel like there's some resistance to that, and I think we just need to shift our thinking. There's arguments to be made for the free market cure. There's arguments to be made for a national health system, and I actually find it interesting the number of people I've spoken with who are pro cash-based care, um, but who are otherwise, they will talk about that and also talk about a nationalized health system. And I think sort of realizing that we're going more of the market solution. And so I think Americans have to become comfortable with taking on that responsibility for themselves. And I think the more employers and companies we see who stop purchasing health insurance, I think that's where the most impact could be made. I think that could really force the health industry and maybe the federal government to make changes if large employers stopped buying health insurance. But there has to be that shift of like, it's no longer the responsibility of your company to provide health insurance. It's the responsibility of each American to go out and find their own solution that fits their own needs. So much more going the free market way, which I find very interesting. But I think it will require Americans to think differently about our health, something that is more personal responsibility as opposed to something that you ought to just get.
Yeah, I agree. I'm with you. I think the where the shift is going to happen, if it's not going to happen by the whole system imploding, is in the corporate America, because that's where it's going to be where the money's at.
Mhm.
And if corporations say, look, we're tired of having to spend so much of our overhead on insurance, which basically is being driven. Now, I know that there are companies now. I mean, I worked for a company for a little while that the way they did it is they had all control of all of their health care dollars, but they used United Health to manage that. And so they had a little bit more say in what could be done. And it gave them a little more flexibility in determining healthcare for their patients. But I still think that until the stakeholders again come back to the patient and the physician, and there's not a lot of interference between that, it's going to be tough. But the patients, our population, to your point, still feel like they need insurance in order to get their healthcare paid for, and that's what majority of individuals will do. It's not going to come from them. I think it's going to come from corporate America, big companies saying we're done. We are now going to provide. We're going to put what we were placing in insurance. We're now going to place in a catastrophic plan plus a direct primary care program. And I think then we'll start seeing shift. As soon as that becomes an incentivized way out, where companies can pay these low premiums, pay for these, high deductible plans, but then they can pay for the direct primary care program, I think they'll save a lot. And I think they'll continue to see a shift in the business of medicine from that standpoint.
I think one of the reasons we don't hear more advocacy is because I think a lot of people don't quite understand how our health system works. And that's something that I try and explain more clearly in my reporting. I think Americans are frustrated by the system, but they don't understand all of the different layers and why healthcare just keeps getting more and more expensive. To your point about AI, I do think we're going to be seeing an AI revolution. I think it's going to make things worse. I think we're going to see the fastest rollout of AI in places where it can make insurance more money. So AI is going to start reviewing your clinical notes and understanding where the hospital might be able to get paid more, or insurance is going to use it to make sure that they're paying hospitals less. So I think that's probably how we're going to see AI be rolled out first. And I've heard in reporting on the piece about doctor burnout, there are a number of hospitals and big networks that are starting to use AI, like ambient scribe tools, which some physicians think are really promising. But she pointed out, hospitals that implement AI tools, they're looking for a return on investment. And whether that's, okay, well, you have ambient scribes, so now you need to see 5 more patients a day, or we have to pass that cost on to someone. It's going to be the patients who have to carry the cost of the millions of dollars it took to develop and implement this AI tool. So, I think while there might be some light at the end of the tunnel, I think AI will make things worse before things get better. Unfortunately, that's what I've been hearing from some physicians and health policy experts, and I could certainly see, just given how our health system is set up to incentivize financial pressures and keeping patients sick rather than healthy. I think we will see AI be used to help people make more money before things really help physicians.
I think that, yeah, that tracks. Having worked in, as a CMIO in a large health system, and then also as a regular kind of physician leader on the administrative side of things, yeah, it's unfortunate how often, the biggest pockets get their agendas, first. So yeah, I think that tracks with what would happen with AI. I am kind of curious, to also hear from your perspective, having lived overseas, if that has also, like, if you've seen healthcare in other countries. I've heard a few stories. Like I'm thinking of this one story where this young man was, describing how his dad, ended up in the hospital in Dubai or somewhere where I don't know, and how, like, they couldn't afford to, like, get the treatments or something. Like it seemed like something that here in America, like, was unheard of, right? Like someone has like a heart attack and you just expect that someone's going to pay for it, but elsewhere they were like pooling family resources and other things to try to make sure that he could get the care that he needed. And I remember thinking, that's odd. Like, it's weird that that burden would fall on the family. But then again, maybe that's just the type of change in thought process we need, here in America. But what do you see comparing and contrasting maybe overseas compared to America?
I think obviously there are lots of different models out there. I was just speaking with a physician in Canada. Canada obviously has universal healthcare coverage, but cash-based care is evidently becoming more popular there too because there are such long wait times. So it's emerging as a solution there. I would say my experience overseas, and obviously it depends on where, the cost is more upfront. Like if you go to an emergency room here in the United States, you're going to receive life-saving care, in part because there's legislation around that, but you will get a monster medical bill later on. It's like a defrayed cost. And in other countries, you have to pay right there up front, or you at least have to show proof of funds before they will even give you care. In a lot of countries, I used to live in Kenya. So at the time, they didn't have much in the way of health insurance. No, they sort of had universal health coverage. It didn't cover, nearly a fraction of the population. What I was so struck by is, I walked in to get care and they said, okay, this is what it is for, I had to get contacts and glasses and an eye exam. And they told me the price and it was like the equivalent of 14 US dollars. I thought, surely I've just not converted local currency to USD correctly. And that was the price. I saw on one hand, the price tag at the end of care that you receive overseas is so much lower than in the United States. That's one thing. But on the other hand, there is, only a fraction of people can access healthcare and can even pay that $14. So it has its own challenges. The other thing I thought was interesting is I used to have global health insurance. So I had health insurance through a company and it covered me in every country in the world. Medical evacuation, anything. And I just had to call them, say, can you make me an appointment? They made me an appointment the next day. I walked in, saw care, never paid for anything, walked back out. This global health insurance model seemed to work so much better than what we have in the United States. And it included the United States in that. So I have wanted to do more reporting on how exactly that is working because it seemed like a very seamless system. It was far more affordable, and it was easy to use. And I think there might be something there if we could just understand better what's going on there. It really worked well, and I used that health insurance in countries you wouldn't think. I was like, "Is there a hospital in this country?" I'm not sure, but it was just very seamless and easy, and seemed like another potential solution.
Yeah, that's really interesting. I'm going to go back and share a couple of stories to highlight what you'd said previously about AI, and then also just this mindset that we have as a society utilizing insurance. So the first with AI, and to your point, we were, this was probably now 6 years ago. We had a meeting with one of the insurance companies, and they were questioning our notes and whether or not they should be billed out under the top E&M code, which is 99215. And so I was there, our office manager was there, we had some legal representative, and we had their quote unquote billing expert on the other side. But I guess she was second in the billing department, not number one. And so as we went through and we're trying to figure out why they weren't paying for this, as we went through the note and I was trying to help her understand that I couldn't see why we weren't hitting all of the points that were necessary to get reimbursement for 99215. And I asked her, I said, will you review this note and tell me where we're still lacking? And her response to that was, I don't know. We'd have to run it through the software. And I was like, wait, what do you mean you have to run it through the software? In other words, she didn't have the capacity as a human expert in coding to be able to give me feedback about whether or not what we said we were documenting was in alignment of what we need to be reimbursed. It had to be run through the AI software first, which is set for certain parameters and it's set up to obviously bias them. And so they will exclude things, and maybe the way that we worded it wasn't exactly the way AI would credit us for that. And I thought that was absurd. So here it was, a human couldn't give me, an expert human in coding couldn't give me a response until it had gone through software. that was frustrating, number one. The second story is also interesting. It was and I think may have told this in another podcast, but there was a friend of mine who was working for an NBA team, and the NBA player wanted to get a more functional medicine gut test. And and so he was asking me, I don't know how to interpret it and stuff. And I said, well, this is the company that I use. Go ahead and order this test, and you can do it through this company, but you can't use insurance for it. And he went back and he told the player, and the player said, oh, if it's not covered by my insurance, I don't want it. And we're talking like a $350 test to somebody who's making millions and millions, has their own cook, has their own trainer, hardly does, probably doesn't even fold his own laundry. And yet he won't pay for a $350 test to find out what's going on in his gut because it's not covered by his insurance, right? That's the mindset that we're in from a society. And it sets things back. It makes things really challenging because people are, oh, why do I have to pay for my healthcare? No, I have insurance. And so I agree. To your point, we've got to get out of this mindset from a society. I love that you're educating people, trying to help them understand how the system works a little better, because it's only through education that we can make better decisions. But yeah, it's a challenge. I think there's a lot of smart people who have good solutions, but ultimately it's going to be the money that makes the difference, and where that money is going to come from, whether it's, like I said before, corporates, sponsors, or through government. It's not going to be just through ideas that is going to change this in medicine. Any other thoughts on that?
Yeah, that just reminded me of an interview I was doing with a primary care physician who moved to cash-based care, and she was describing how, our healthcare system incentivizes sickness. You come in, you have obesity, diabetes. Okay, here are the medications that you need to take. Keep taking these medications. There's no time and there's no reimbursement for discussions around nutrition or lifestyle changes. And so they don't happen. And so the system keeps getting reimbursed and that patient stays sick. Whereas in the cash-based model, it's a flat fee per month, no matter how healthy or sick you are. And so it behooves physicians to keep their patients as healthy as possible so that they don't come into the clinic as much. And so it's also just such a shift in incentivizing keeping patients sick, which is not the goal of physicians, but it's the goal of our healthcare system,
Right.
versus a cash-based care, which truly incentivizes keeping people healthy. And that can evolve over time because you're stuck with billing codes or the lack of billing codes. You can adjust what each patient needs. You can adjust over time much faster than the federal government will change their policies on reimbursement. So I think it really just most importantly represents a huge shift that will really benefit Americans and make us healthier. And so I would really like to see more policies that support the movement to that direction. But as I said, it's not the end all be all solution to our healthcare challenges in this country.
Yeah, I agree. And I think, hopefully, there is a movement right now, and there's some who oppose it, but, the Make America Healthy Again, some of the initiatives, I just saw an ad that actually, this month, if you want to apply for a grant to be able to study the impact of lifestyle and nutrition in your clinic, they will give you a grant to do that. They're trying to incentivize, they're trying to move more of this into the practice workplace. I think again, it's a challenge because right now there aren't any cost savings through insurance to incorporate more lifestyle and nutrition. You have to get it outside either by patients paying a membership or getting a grant from the government. And until that really shifts, we're not going to see great strides made, but at least we're starting to see some movement. It's getting talked about and at higher levels and getting publicity, and all of that's positive.
One thing maybe you could include in a future article, I think if we plant some seeds out there, maybe there will be some people in our political leadership structures who might take notice, right? You never know, we might get lucky. But something that's come up a lot is people will ask me, because I think the consumer that's interested in a direct pay model, some of them are the type that are self-insured or or maybe they're going without insurance temporarily, right, while they figure things out, have asked me, will this count as my insurance requirement? Because there is a law now that says if you don't have, you have to be paying something for insurance or you're going to get taxed or something, right? Whether or not you agree with that kind of legislature is a different topic. But given that that is a requirement, it does seem like it could be a nice compromise, right? Where if direct primary care or other direct membership type models that at least satisfy some sort of healthcare coverage could help people with that, check that box. It might help drive a little more in this direction, and again raise some awareness and at least make a small change. So I don't know. What do you think about that?
Yeah, my understanding is that that's not at the federal level, that's at the state level that impose those fees on people who don't have insurance. And it's a fraction of states now that still impose a fee for people who are not insured. Um, I was chatting with someone. I'm reporting on a piece right now about the rise of functional medicine and what is that. And they were touching on both functional medicine and cash-based care, and they were bringing up this criticism that it introduces this. One of the reasons people like functional medicine and cash-based care is because it gives the control back to patients, and patients can feel like they're in control of their health. And personally, I think that's a good thing. But he was saying, it also introduces this element like, well, if you're sick, then you're a bad person. You haven't done everything you can to be healthy. And I've heard that from a number of people who are, see cash-based care as sort of putting the control and responsibility back on the patient, and that is maybe not the best thing to be doing. So, and I think that's a big part of the MAHA movement as well, is who has the freedom and responsibility over their health? Is it the healthcare system or is it the individual? And is there a component of, well, if individuals are responsible for their health, that they're a bad person if they become sick? And so I've been hearing that conversation a bit more, which I think is interesting. Personally, I think everyone has responsibility for their own health, and I think that's one thing that the cash-based model and especially direct primary care will help empower patients, but it will also give them the tools, which is a physician to go to with questions instead of turning to whoever is saying on TikTok and, well, let me try that for my cancer treatment instead. So I think there's, with the MAHA movement, we have the question of what is the individual's responsibility and what is the responsibility of the system. So I think we're going to start to see more conversations around that. My biggest concern, I think there are some really great elements of the MAHA movement. My concern is just that science and health has become so politicized and so polarized that no matter what one side of the aisle does, the other side is going to oppose it. And I think we're at such a time where everything is so polarized that we're not going to reach solutions, even when a solution might be warranted, because we're just going to be feuding about politics. So, as much as I'm optimistic about cash-based clinics, my concern is that it's getting wrapped up into functional medicine and MAHA and RFK Jr. and is going to be dismissed wholesale just because it's politicized.
No, it's a very good point, and I think the moral and ethical debates, that these bring up these topics, right? And I think it could go beyond healthcare, right? Like what is someone's responsibility in their own life, whether it's for their finances or to take care of their children or whatever, right? Like you could draw lots of different parallels. But I think we find that balance, hopefully, as a society, right, where we say, hey, there's nothing wrong with trying to learn about the value of taking responsibility and how good that feels, and the fulfillment and satisfaction that comes from, setting goals and accomplishing things and creating value in your own life. But then we have compassion for those that maybe are overwhelmed or that are up against, unreasonable odds, or their capacity maybe based on, for whatever reason, in terms of how they compare to others with their ability to manage their own resources. I think we can have both, right? I think we can, encourage responsibility because of the consequences that brings, and but not judge others who, don't have the capacity necessarily, or are going through a difficult time, right? And I agree with you. It's unfortunate that these things become a political, sword to die on, versus just taking a more broad, comprehensive approach to how do we, come together as humans and help and support each other.
Yeah, and to your earlier question, Davin, too, to piggyback off what Jessica was saying, one of the things that policy has stated is that this year you can use your HSA to pay for direct primary care, which is, I think, a big boost in this area. And the other is that there are, I'm aware of several health share companies, which isn't insurance, but it does allow, you can get credit for having insurance if you have a health share plan. And those health share plans are now also saying, if you want to do direct primary care, we will pay up to $150 a month for a direct primary care program out of what you're paying for us. Of course, it has to meet their qualifications. And unfortunately, a lot of them don't think that functional medicine or integrated medicine meet the qualifications. They want more conventional direct primary care programs. But nonetheless, we're at least seeing that start to emerge as possible ways that patients can get some coverage, some catastrophic, and also get their quote unquote health share plan to pay for their direct primary care as they contribute on a monthly basis and participate. And I think the evidence is going to start to bear out that those individuals who participate from a care standpoint actually probably have fewer hospitalizations, have fewer urgent care utilizations, fewer emergent care utilizations. And so the overall cost savings is pretty dramatic above and beyond that. So it's going to be really interesting. Well, we're coming up on an hour, and Jessica, this has been a fantastic conversation. It's been fun to kind of wax philosophical on a few things and theoretical, and actually, give our wish list out there a little bit. But I let Davin kind of bring us home with the final question here.
Jessica, with what you're kind of interested in, and where you see like the needs of sort of like educating or opening the eyes of the American public, what are some topics that you think we should explore here on the podcast, or that you plan to explore through your own journalism?
Yeah, going back to what I was saying about the politicization of science and health, I think something that is really important for me as a journalist and for anyone putting content out there about health is to really just acknowledge both sides of a political argument. And I try and do my best to stay open-minded. In fact, I try and if I have a strong position or opinion on something, by the time I finish my reporting, I've been trying to convince myself to agree with the other side. And, I think there's a lot of importance in exploring and asking questions. And sometimes that can be demonized as being, on one side of the political aisle or not. But I think, really pursuing and asking questions, pursuing different perspectives is really critical, but also returning to the evidence and acknowledging what evidence we have and what evidence we don't have. A lack of evidence at the outset of an idea doesn't mean that something's not going to work out. But I think it's really critical as a journalist and as communicators that we acknowledge this is an idea, this is the evidence we have, this is what we don't yet know. I think that's a huge lesson that we learned from public health officials during the pandemic, is just to say what we don't know, to acknowledge that science is not black and white. It's constantly evolving, and we just need to embrace and acknowledge that so that our American consumers can be more aware and they can make their own decisions.
Well said.
Love that. Well, thanks, Jessica. It was really fun to have you on the podcast. We're so grateful that you reached out and asked to participate, and we all benefited from the discussion today, and we look forward to hearing from our listeners to hear what they have to say, and let us know what you think. How is medicine going to change? Is it going to be people standing up and demanding a change in healthcare? Is it going to be corporate entities that are going to demand the change in healthcare, or is it going to come through our politicians? You let us know by commenting in below, and let us know what you think. So thanks, Jessica, and we look forward to seeing your articles in the future and what you're continuing to write about.
Thanks so much for having me.